Afternoon, everyone. 1:15. Let's just give it one more minute just to give a few more people chance to log in, and then I'll kick off. So one more minute. Very good. Afternoon, everyone. I suggest we kick off. So normal rules. If you're not speaking, if you could switch the video off to give us the bandwidth, and make sure you're on mute. Just makes it easier for everyone else to hear. That would be great. And if people have got questions, do try and put them into the chat bar, and we'll do our best to answer as we go along. So I've got 2 or 3 updates, and then we're going to do a little bit on population health management that Katie Summers is going to sort of take us through. So let me just give you a couple of updates. So I think this time last week we were saying let's hold for a couple of weeks before we think about going into the office. I have to say, if you think about what happened over the last week or two, we'll still review in a week's time, but I suspect that will be harder for us to see a return to the office. But anyway, let's see where we are in another week or two. But I expect, like many of you, we are looking slightly nervously at the rising COVID rates, and many of us wondering, how schools and the school bubbles are really going to work. The second thing I wanted to cover is, obviously last week I talked a bit about the priorities for the system over the next few months. Talked about making sure we've got all the services back up and running. So that's planned care, urgent care, the cancer services back up, and in primary care, the right capacities and the ability to focus in on some of the screening and the long-term conditions. The second priority, to make sure we've got a good plan for winter, recognising this one feels as if it's going to be more challenging than most, with risk of both COVID and flu, and us transitioning out of the arrangements with the European Union. So that's our second priority. Obviously, the third is monitoring COVID and making sure we've got the ability to be able to flex resources between the needs of COVID patients as well as our normal services. I think there's a strong desire not to sort of switch everything off as we had to do in the first phase, and use the learnings from that in order to be able to flex. A strong focus on inequalities, and that's one of the reasons why I wanted to thought it'd be helpful to get Katie on the call to talk a bit about population health management, because actually that's one area where we're rediverting an existing program to really look at how that can be used to support inequalities. And then finally, on workforce, making sure we're dialing up what we can in terms of well-being, as well as starting to putting in place actions that will ensure that we have racial equality across our workforces. So those are the 5 areas. I would say, by the way, we have a meeting with Anne Eden later on this week, which will be going into detail on all of those and probably more in terms of where we are as a system and what else we need to do over the coming weeks. So a thank you to all those who've contributed to those, the prep for those meetings, and I'll give you feedback of where we've got to this time next week. And then the final thing I wanted to say is just about flu vaccinations for all the CCG staff. So yes is the answer. There are plans in place for everyone to get vaccinated if they wish, and I encourage everyone to do so. I think in Buckinghamshire, it's a voucher system, and contact Dawn Riddell if you need a voucher. I think she's already sent that note out. Oxfordshire is still working through the exact process. It may well be it may well work through as you get it done through local community pharmacy and e-expense, but we'll get the details out to Oxfordshire, and then Berkshire West is likely to run a number of different clinics, either in the offices or with the Occupation Health Department at Royal Berk. So again, we will get those details out to you over the course of this week, and obviously encourage everyone to get vaccinated as and when they can. So that's all the updates from me. As I said, what I was now going to do is hand to Katie to talk a bit about the population health management and the work that we're doing, and and how we're sort of reshaping a bit of that work to focus in on inequalities. So Katie's biggest challenge here is she's just come off, there was a sort of 3 or 4 hour workshop, was it last week? Which I think about 60, 70 people attended across the patch. So it's a popular topic and there's a lot to say. So we're having to pick selected highlights. So Katie, over to you. You have the time and the space. If you've got questions for Katie, why don't you stick them in the chat bar, and we'll see if we can sort of sort those through towards the end. Otherwise, Katie, over to you.
Okay, thank you very much, James. I'm just going to ask if people can actually hear me.
I can hear you very clearly.
Yeah, can hear you loud and clear, Katie.
Brilliant. So I'm going to whiz through this, but as James has said, if people could put questions in the chat, but I'm also going to be giving you an update about certain things I'm going to be doing across Bob, which actually I will be able to engage more widely across all staff about population health management. So I work at the moment in Berkshire West CCG, where we ran a Wave 1 population health management programme last year, and we're now running a population health development programme across the whole of Bob. So why population health management? So effective population health management is a common theme across a number of the actual priorities that have been coming out via the NHS, public health, and other systems. And quite recently, the phase 3 letter, which is outlining recovery and ongoing management of COVID, has addressed an urgent action for us to think about health inequalities, but also think about that in a PHM starter fashion. So what is population health management? Now, it's going to be quite hard for me to do this, as James has said, it's a 3-hour meeting. I'm condensing this down into sort of a 15-20 minutes, but this is a quick, sharp answer for you all. So what is population health management? Well, simply as possible, it is about improving the health and well-being of groups of people or our population. Now, you might say that we're doing this already, but where population health is different is that how we do this is that we segment people with similar traits, conditions, or health areas. And when we actually segment those people, we would then think about how we respond to those individuals in a tailored way who have got similar traits. So a good example of this is, in the past, we've been really heavily focused on diabetes. We've been thinking about running a national diabetes programme, but we haven't been thinking about the differences of people's similar conditions or traits on that. And actually, when you break it down into how you would actually then think about the delivery of that, you may want to flex how you deliver the actual diabetes programme. When we think about the actual recovery of our system, we know that only about 20% of actually an individual's health outcomes are actually affected by their actual health. So if I take the diabetes example, only about 20% of that actually affects someone's health outcome. But we've got major other things that we've got to be thinking about. The environment, so housing, quality and the built environment, social factors such as education, employment or income, and their behaviours such as smoking and diet. Now, at the moment, I think what we tend to do at the healthcare service, we tend to just keep focusing on the healthcare. But if you think about if we started to really examine behaviours and social, economics and environmental factors, that's when we're truly only going to actually benefit from actually delivering the overarching aim of our systems going forward. PHM supports a proactive personalised care model for those with identified risk or vulnerable data. So this is something that's actually pulled together via NHS England that looks at both the routine and reactive management of people with health and care needs and the compounded detrimental effects of the pandemic. So you think about this, we identify those people at risk for ongoing COVID management, for infections, and those that health are deteriorating, and then going all the way through to support more proactive, personalised, empowered, digitalised approaches at scale. So what we've got to be able to do is actually go across this actual area of focus, and we've got to be thinking heavily about the health inequalities as we move forward. As I was saying, we've got a population health development programme. This is a 22-week programme. It's been run, it's only literally kicked off, and it's quite intense. We're looking at both the infrastructure, we're looking at intelligence, and then looking at interventions. We've done some work at the moment on the actual data, and I'm going to present some of that data to you during this call. But what we are going to be doing is focusing heavily on places and PCNs. For the places, there's going to be detailed workshops both in Bucks and Oxford, and the Bucks one is actually kicking off on the 24th September. So there's going to be lots and lots of opportunities for all the staff to be heavily engaged with this programme going forward. The interventions are going to be done both at a PCN area and also a place. At the moment, PCNs, we've got 6 of them, and they're across Oxford and also Bucks, but we are looking to potentially expand that going forward, so we have more PCNs involved. I'm pleased to say we've got some really clear data coming forward, and that's been overseen by Cecile Cognit in Oxford, and she's pulling together with the Optum team who are actually supporting this actual programme really sophisticated data packs to help with both the PCNs and the places and the ICSs in order to really focus on health inequalities and the COVID risks in the PHM going forward. So what I'm going to share to you today is some of the linked data that we've already analysed for the actual programme. And what this programme is actually looking at the moment is information from wider determinants, general practice, acute, community and mental health. In an ideal world, we also want to be expanding this to incorporate adult social care and other areas such as police and housing. But in the future, that's one thing that we will start to build on, but it won't necessarily be part of this 22-week programme. So let's look at some of the data that we have already analysed. This is hot off the press. This was presented last week. This is looking at some of the overarching psychosocial risks for the overall population. So what the Optum team did here is they looked at the 6 PCNs data, that's 3 from Bucks, 3 from Oxford, and analysed this from the psychosocial risk factors. So those with no specific mental health and social risk factors, mental health, social risk factors, and social risk factors and mental health. And you can quite see here that actually we've got pockets of people that we actively need to start to work towards. And this is a way that we could think about it from a place in the PCN about how we start to target individual interventions to support people at risk of COVID. We break that down even further. This is when we can actually see some of the overarching opportunities. So you can see here, this is again with regards to the low risk, single long-term conditions, multiple long-term conditions, and very high clinical risks of COVID. You can see here the population sizes. Now this is again for the 6 PCNs, and you can see the variance in the average ages as well, and the BAME communities. And this is, you can see here, we've got some opportunities to really focus on cancer. So obviously there's a lot of work that's been going on for cancer, but we've really got to make a big focus on supporting those people with COVID, with cancers, to prevent those people from deteriorating even further. And then we break it down into other areas such as depression and mental health. So from here, we know that actually what we've got to be doing is not only thinking about the physical health, but we've also got to be thinking about the mental health of COVID, and actually how do we support those individuals that might be deteriorating. You could then break it down even further, and you can look at it from the point of view of PCNs, and this is where it starts to become live. So for example, if I take Signet, that population here obviously is got 35% of their population is from the BAME community. Their average age of that population is 38 compared to the other areas, but they've got significant risks going forward regarding how they support those individuals. And this is where it comes into play about how do you support those people with a social economic and also a housing problem, and actually how we've got to think about how do we think about changing and supporting those individuals going forward. So a good example of this is in Berkshire West. One thing that we're looking at is the BAME community and also the actual deprived areas from a flu perspective. And we know that actually these individuals are less likely to go and visit their GP practice. So one thing that we're working now with is with the food banks and also the local communities, such as going along to mosques and temples and delivering the food campaigns to those areas as well. So that really makes a real difference to supporting our actual campaign to support those people and encourage flu uptakes. You then kind of look at it from a multiple risk factors perspective, and so this is some of the information that we have here on those areas. So we want to be thinking about it especially from the point of multiple long-term positions and COVID risks, and how we start to think about the individual. So you've got to be thinking about it in a multi-morbidity way going forward. The final thing I want to present to you is very much about how we think about the actual identifying those groups that are at risk of an emergency admissions. So what this bar does here is look at the actual clinical episodes, and we know here, for example, there's around about 8,500 people that are recorded with depression, and that means that the model suggests that for every one admission, additional admission, that's for every 6 people. So we do know that depression needs to be heavily monitored and supported for the emergency admissions going forward, rather than the actual clinical episodes such as COPD. So we've really got to think quite differently of how we're actually supporting our services. So this was a really short, sharp fire whistle of the population health management programme. If you go to the Bob ICS website, one thing that I've done is I've done a video with one of the actual clinical champions, Dr. Dan Alton, who's now the actual one of the national clinical advisors for population health management. And that is an 8-minute video. It talks about population health management. We're also going to be sharing the outputs from the programme with the ICS Comms hub and also through a Kahoot site. So if people are wanting to get involved with it or find out further information, then please contact and look at the ICS Comms hub, because that's where we're going to be actually sharing a lot of information going forward. The final thing I really want to ask is if people are really wanting to know more about population health management. So if you could put your hands up whilst I'm actually just giving the further information. So on the 25th of September, one thing I'm organising is a PHM clinic. So I'm going to be rolling these PHM clinics out for over the 22 weeks, and I'm going to be holding them every other week. And this is where you can come along, you could share your Pacific challenges and actually speak with Dr. Dan Alton, with the Opton team, with analysts, and they could actually give you suggestions about how you could actually improve the actual health outcomes or actually oversee some of the challenges that you have going forward. So I appreciate this is a really short, sharp whistle stop of population health management as it is at the moment, but I'm hoping that gave you a snippet about what I've tried to condense from a 3-hour meeting into 20 minutes. I'm welcome to ask questions.
Thank you, Katie. Really, really good. Now, Katie, when you said put your hand up if you're interested, did you mean on this call? Because you've got vast numbers of people putting their hand up, or how do you try and do it?
I think it'd be really helpful if I could get, we've got 13, maybe more people putting their hands up. That's great. So I'll log who's putting their hands up, and I will actually then do some personal emails to those individuals. I will also send out, if this is okay, I will send out the link to the actual PHM clinic. I'm going to video the clinic as well, and that will be available again through the IS website. If people are wanting to ask questions, then I can do it that way as well. So I think it's 2 things: hands up, and if there's any questions that people are wanting to ask, then I'm happy to answer those during the meeting.
Fantastic, Katie. So I'd say, I think you've, why do we have the hands up for those who want to get more involved? Then if you've got questions, put them into the chat bar. We've got time for a few questions, I think, if people have got them. You've got one from Lynn about who will have access to the materials, and I think you may have covered that off towards the end, Katie. So I think you've covered that. Will this be expanded to children and young people? I think is another question. I think you only gave us a small slice anyway, but what's your thoughts on the?
So the program is expanded across the age band, so it's just not focusing on just adults. It can focus across everybody as such. If people are wanting to take a specific focus on children and young people, then that's something that we can organise as such. So if people are wanting to do some of that work, I know that in Berkshire West we've been talking about children and young people as well. So I think that's something that we could organise. It's also worth noting that in each of the places you already have population health programme boards. So you could also, the programme is being overseen by those programme boards, so you can take your questions or your asks to those individual places population health programme boards as well.
And then Raj, if you can see the question from Raj, will frailty be included as a risk factor for preventable admissions?
It can be, yes, it can be. It's actually one of the conditions that we've looked at as such. We've got what we have in the actual programme, or NHS England have actually given to us, is a map of the specific conditions that actually are pertinent for COVID-19 at risk. Frailty is one of those areas, so we will be doing it at frailty as well. Frailty is an interesting one because what we've encountered in Berkshire West is that if you're frail, you are at risk of actually having a COVID admission, but also if you're from the BAME and deprived communities, you're exactly the same risk. So I think it's an interesting piece, but we will be giving it for frailty as well. Seem to have lots of hands up, James. Yeah, so I'll keep a log on everybody. I'm going to try and think about how I log all of these. I will keep a log of everybody.
Hey. It's Karen. Yeah. I'm logging it.
Oh, thank you very much, Karen.
You got someone helping you. Very good.
That's Karen, my PA. Thank you very much, Karen.
And Katie, I've got a question. With your clinics, is it helpful? Could you just go back through? Is it helpful for people to send you some of the questions in advance, or some of the topics in advance that they might want to ask you? And then again, just clarify, what are the best things to bring to the clinic versus what might be the best things to bring to the local board? I mean, I don't know whether you want to act as a central broker in all of this, or whether you can divide the questions, but that may be helpful just so that people know where to turn to.
So for the actual PCMs, they have what's known as action learning sets, and some of those action learning sets are creating their own challenges themselves. What I'm proposing from the clinic is this is an all staffing opportunity. So if people are having individual queries or challenges, this is almost like becomes an advisory board for the actual ICS, and we've got access to a national advisory body through Optum. That's an international advisory body, and we can actually have questions posed to us. We can take that to the national advisory body, and they can actually give potential opportunities about how to overcome those challenges. So probably what I'll do, James, is I'm going to be sending out an email, if this is okay, to everybody. People could raise their individual questions. I'll be raising it with the international team to see how other areas across the world have overcome those individual challenges.
That sounds fabulous. It sounds like you're taking on a lot of work, Katie, but let's see what the questions are and how many you get. Clearly, certainly from my perspective, as you see, how, systems and places evolve, the ability for us to use data, use some of the existing data, expand some of the existing data, but more importantly, do the analytics in this sort of way, particularly the cross mapping of one data set with another to really give us the sort of insight, is one of the really important capabilities to dial up as we move forward, because it's the way we're really going to sort of make sure that we get health targeted at the right people and particularly if we're in worlds of COVID where we do need to prioritise, it becomes even more valuable. Can I check, are there any other questions for Katie? There's obviously a huge amount of enthusiasm, Katie, so thank you for covering the topic off. I would urge people to look at the resources. I wasn't able to do all 3 hours of the workshop, but I did do a good hour and a half of it. And actually, there's an immense amount of richness in some of the data that's coming out. So it is worth picking up and having a look through those resources. And I'd recommend folks use the clinics and use the resource that we've been given, and test it out a little bit. So there's one other question come through. We are developing these linked data sets and analytics in the background to continue beyond the Optum. I don't know whether that's a statement or whether that's a question, Katie. I'll leave you to.
Yeah, that's Cecile. Cecile is my PHM analyst specialist. It's basically what she's doing, and she's put here's the statement. So basically, she's pulling together an analyst community as such, and it's bringing together analysts from public health, local authorities, the acute community, and the CCG. What the Optum programme does is give them the new skills and additionals about how they could actually start to work with those linked data sets to really think quite differently rather than just looking at performance. So as she says here, it's going to go beyond the actual Optum programme itself, but Cecile's doing a lot of background work for us on this going forward.
And will that, final question for me, is that just on the 6 PCNs, or are we trying to work out how to mirror the same data sets across all of our PCNs? How will that roll out?
Yeah, so at the moment we're just doing it on the 6 PCNs, but also we're doing it at the places. So Oxford and Bucks will have place level data as well. So what they're going to be doing is aggregating the data and linking the data for the places. So that's going to be for Bucks and Oxford. We've already done that in Berkshire West. So you're going to have a lot of information actually linked going forward. So it really would help understand and support the overarching priorities, James, as you have actually outlined several times now in these all staff briefings. So thinking about the waiting list agenda, thinking about the flu campaign, thinking about COVID. So we can think about it in a way that we do it at a system level, a place level, a locality level or neighbourhood level, as well as a person perspective as well. So we can start to flex the actual system going forward.
Fabulous. Katie, thanks ever so much indeed for that. Really enjoyed it, as did, I think, the vast numbers of people who are putting their hands up, and you may even get more coming back, I suspect, on the email. But if you could put an all staff email out just to sort of let people know when the clinics are, again, I expect it's worth resending out the links that you had at the end of the presentation. Otherwise, thank you, very much appreciate it. Thank you everyone for joining. I think we're back at 160 of you, I think. So thank you, appreciate that, and have a good rest of the day. Really helpful. Thanks, Katie. Bye, everyone.
Karen, have you got everybody recorded?